Thanks, guys. Hi, everyone. Thank you for joining us on this Monday of the Thanksgiving week. We have a great talk for you guys today. I'm Michelle. I'm the education coordinator for BloodNet. I'm very pleased to announce this title called Immune Dysfunction in Critical Care and Considerations for Use of Immunomodulating Therapies in this critical care population. So for CME credit, a lot of you guys have already registered through the platform. The code today is JOGMOZ, so you can text that to this number here, or you can always navigate to this Children's Colorado site and then put the code in for you to be able to get 2 of this CME credit. So our learning objectives are listed in the flyer, but just like a briefly going through it is that we're going to describe immune dysfunction physiology in the critically ill patient population. We're going to distinguish between immune suppressive and hyperinflammatory conditions seen in the critically ill population. We're going to talk about CAR T cells and therapies for CRS. And then we're going to evaluate considerations for use of these immunomodulatory agents in the critically ill patients. It seems like they're coming out faster than people know exactly what to do with them. Our outline, so we're going to go over immunology and the immune dysregulation of the critically ill patient by Dr. Mazur. Dr. McAvoy is going to talk about CAR T cell therapies and CRS, and then our Q&A session will be moderated by Dr. Remy. So with that being said, I'm going to unshare so that Dr. Mazur can share his slides. And so Dr. Mazur is an assistant professor of pediatrics in the Division of Peds Critical Care at Case Western Reserve and also practices in Rainbow Babies there. So I'll hand that over to you.
Thanks very much, Michelle. So this is a very extensive topic. And so the way that I tried to break this down to really touch upon the most important things for us critical care thinkers is to understand the basic pathways of the immune system, how the body responds to different stimuli, and then what we might be able to do about it in a targeted or not so targeted fashion. I don't have any financial disclosures. I do have my name on a patent for whole blood ELISpot and immune phenotyping, and kind of went through the outline, but instead of breaking everything down by section, I really put different parts of the immune system with their immunomodulatory therapies together in an effort to try to really bring everything together to make it more understandable for everybody here in the audience. So where does immunomodulatory therapy come from? The so-called father of immunotherapy for cancer immunotherapy is William Cawley, and he lived at the end of the 19th century and recognized that certain patients with inoperable sarcomas actually had spontaneous resolution of their cancer after sustaining certain infections, specifically erysipelas, which was likely from strep pyogenes at the time. And so when he figured this out, he decided maybe I should inoculate people with these inoperable cancers with this bacteria and see what happens. And he actually has had some really interesting results and had some really amazing outcomes. And over time, built this new idea of how at the time wasn't known that he was modulating the immune system, but was taking an immune system that was suppressed because of the inflammatory response and the tumor microenvironment that was ongoing, re-stimulated it with this infection and caused the immune system to then attack the cancer. And this was the beginning of cancer immunotherapy. And although his particular method is no longer used, that was the basis for a lot of the immunotherapies that have come out. And you can see over the last several decades, there's just so many new ways of modulating the immune system to try to target cancer. And so when I think about critical care immunotherapies, really the question is, just like in cancer, where you have changes to the immune system because of various stimuli that cause the immune system not to function as it's supposed to, are there ways in infectious diseases, traumas, post-surgical patients, or other autoinflammatory and autoimmune diseases that we can modulate the immune system the same way? Because we know that the immune system is circulating throughout our entire body, and it's responsible for many of the effects that happen, whether it's from infectious diseases or traumatic injuries, surgical patients, asthma and allergies. and various other things that we see in the hospital and in the ICU. So I put this together. Let me see if I can, there we go. Which is kind of the formulation for the way that I think about the immune system in response to various stimuli. And in reality, we should have a nice homeostatic response where there's inflammation, there's balanced anti-inflammation or regulatory mechanisms. And once the damage or the inciting pathogen is gone, the immune system comes back to its baseline. However, we know that there's some patients who develop hyperinflammatory response, and they develop high fevers, multi-organ failure, shock states, and a lot of these patients end up dying. There's also a subset of patients that not only have high levels of inflammation, but persistent inflammation over time, as well as persistent immune suppression over time. And what that means is there's an ongoing inflammatory response with balanced but suppressive dysfunction of many of the cellular functions that are required to fight off infections and induce wound healing. And so we'll go through some of these mechanisms over the course of the next several minutes. But ultimately, patients who develop this persistent inflammatory and immune suppressive response develop opportunistic infections. They're at risk of mortality several weeks to months later after their inciting injury or infection. They have decreased muscle mass. They have neurocognitive decline. They're physically disabled. And this is what was coined by the Florida group with Moore and Moldauer, persistent inflammation, immunosuppression, and catabolism. And so this is kind of a mechanistic approach for why patients get chronic critical illness, but how it stems from early on during their illness in the ICU. So we're kind of shifting now from this bimodal high inflammation followed by suppressive anti-inflammatory response to a conjoined overexpression of inflammation and over suppression of the immune system, which both of which needs to be targeted in our immunomodulatory therapies. Now, why does dysregulation happen? There could be many reasons. You can have genetic predispositions. You could have inborn errors of immunity that target very specific mechanisms. There could be environmental epigenetic changes. It could be with age or comorbidities. You can have up or down regulation of one or two signaling pathways that could ultimately cause this imbalance. And then there could be ongoing damage to tissues that are just increasing inflammation and causing the inability to downregulate the whole response. So we're going to start with anti-inflammatory therapies. And the anti-inflammatory therapies range from non-specific to very specific. But before we do that, just to think through very specifically about how the immune system works. So whether you have a pathogen invasion or you have an injury inside or outside of the body, they will create damage to tissues. And the damage to tissues will send off signals, which are either pathogen or damage associated proteins, but these proteins will be recognized by the most primitive pattern recognition receptors and very simplistically cause a downstream signaling response that then transcribes proteins. And those proteins are then released into the rest of the body to signal that there's either an infection or damage to tissue. Every epithelial cell in our body is able to secrete IL-6 and IL-1 beta to signify that there's an inflammatory response to try to call for help and bring the rest of the immune cells to the location of the infection. Once immune cells that are sitting in the tissue are activated, they start to secrete more inflammatory cytokines to improve recruitment, bring in neutrophils, macrophages, monocytes from the periphery, from the lymphoid tissues, so that they could initiate the initial innate response. And then innate response is obviously not specific to the antigen, but it's just trying to control any damage that's occurring until the adaptive immune system could be activated and initiated. So all of these cytokines are secreted. They are secreted systemically as well as locally. So you have activation of endothelial permeability and vasodilation in order to recruit cells specifically to the site of infection. But if you have an injury, you also have vasoconstriction because you want to decrease as much bleeding as possible and isolate the injury to that location. Increased lymphatic flow, you have recruitment and chemotaxis of leukocytes from the secondary lymphoid tissue, as well as the bone marrow, thymus, lymph nodes, so that they could activate this response. At the same time, you start to have antigen-presenting cells, which are the dendritic cells, macrophages, and they'll be able to take small pieces of those peptides back to the lymph nodes, where they're able to activate T cells and B cells to initiate the adaptive response. So what happens when there's hyperinflammation? Hyperinflammation is just when there's unbalanced of the pro-inflammatory and anti-inflammatory responses. But if you have more inflammation and it's ongoing inflammation, then you're going to have persistence of your vasodilation. You're going to have a shock state. You'll have decreased perfusion to tissues, but you'll also have ongoing injury to tissues from these inflammatory cytokines. And that's where we end up getting these hyperinflammatory responses, but you also have some more syndromic-like inflammatory responses, some of which are autoimmune because there's various autoantibodies, and some of them are just increased secretion of cytokines. And recently, we've had experiences with MIS-C. We all treat Kawasaki disease, post-infectious myocarditis, so targeted organ-specific attacks from this inflammatory response, Guillain-Barré syndrome, and any infectious or post-infectious encephalitides. So what's the first thing that we all think when we try to decrease the inflammatory response is use of corticosteroids, and that is first-line therapy for many autoinflammatory and autoimmune diseases, especially flare-ups of several of the autoimmune diseases. We use steroids as first-line for asthma. We use it to decrease edema and swelling. We use it to decrease inflammation, but we also have to be cognizant of the fact that corticosteroids are lymphotoxic. And so depending on where during the cycle of T and B cell maturation they are, some of them are highly sensitive to steroids and can undergo apoptosis from steroid administration. Stress responses endogenously are also associated with T and B cell apoptosis due to the increases in steroids and increase in catecholamines. So we have to be thoughtful at least about when we're using steroids, but some diseases really steroids is the ideal choice, and others, when you don't want to ultimately suppress the immune system, might not be the best choice. So now we have several targeted anti-inflammatory therapies that we'll go through, but unfortunately, none of which have really been shown to cause mortality benefit or even clinical improvements in several of the syndromic cases that we take care of in the ICU. Definitely not sepsis, but using anti-TNF alpha inhibitors, IL-6 inhibitors, which gained a lot of popularity during COVID, and IL-1 beta inhibitors, such as anakinra. Some of these are wonderful drugs and can be readily used for hyperinflammatory disorders. But before we use them, we really have to understand whether or not the injury is from ongoing hyperinflammation or if there's something else that's going on. IL-17, I think, is an interesting one, which is highly effective in psoriasis, but has never really been shown to have much effect in any other rheumatologic or autoimmune disease process. However, IL-17 is a very important molecule when it comes to inflammation systemically. One important thing to note, though, is when you specifically block TNF alpha or IL-6 or IL-1 beta, as opposed to steroids, you're not actually suppressing the innate and adaptive immune cells. All you're doing is blocking the one specific cytokine response. And so it's possible that utilization of these medications could be safe in critically ill patients because it's only blocking the one system or the one cytokine that's causing inflammation. On the other hand, if several cytokines are elevated, blocking one of them might not make much of a difference. When we think about asthma therapies, we use corticosteroids a lot in our asthma patients, but for the more severe asthmatics, there are now several biologic therapies that are utilized. We have an anti-IgE inhibitor, which are more for chronic management of asthma, but several of the other ones that block eosinophils are actually being trialed in the acute setting to see whether or not that could decrease severity of disease and improve outcomes with patients with asthma. There's also another biologic therapy that blocks thymic stromal lymphopoietin, which is secreted during an asthma exacerbation, and that's also undergoing clinical trials to try to block that process, which is the allergy asthmatic process, as opposed to the hyperinflammatory process of infections and injuries. Now, we already talked about the fact that blocking a single cytokine like TNF-alpha or interferon gamma might not downregulate the entire system. And so using inhibitors of downstream signaling pathways might actually be helpful. And so there's several JAK inhibitors which are used in cancer therapies to decrease inflammation and augment immune function. This was also trialed recently in COVID patients, and there's a meta-analysis that was published a couple of years ago that did show that at least in some of these trials, JAK inhibitors were useful for critically ill patients with COVID-19. But again, really understanding the mechanism behind each patient's critical illness can be helpful to decide whether or not blocking the response to inflammation, as most of these JAK signaling molecules are attached to receptors for things like IL-6 and IL-1 beta and TNF-alpha. But if the problem that the patient is experiencing is not hyperinflammation, then maybe these aren't necessarily the right tools. In Europe, there are several extracorporeal filters that are supposed to be able to completely remove cytokines from the systemic circulation. So instead of blocking with monoclonal or polyclonal antibodies, we run an extracorporeal circuit during the acute phase of a patient's infection and can absorb all small molecules that are causing the inflammatory response. However, unfortunately, and one of the reasons why it's not yet approved in America is because none of the studies that have ran randomized controlled trials, as you can see in this meta-analysis that was published this year, whether it's for patients with sepsis or post-bypass surgery, other severe illnesses, COVID, or post-cardiac arrest, have shown any changes in mortality outcomes. And so despite the fact that this sounds like a really nice way to manipulate the immune system and minimize the hyperinflammatory response early in disease, it hasn't shown the outcome benefits that we would have liked to see. There are several other filters, some of which are attached to dialysis filters, and so they can be run together with dialysis. Others have molecules like polymyxin B, which can specifically bind to endotoxins. And so the thinking is that if you can continually remove the toxins that are mediating the immune response, that would be helpful in improving patient outcomes. But of course, so far, there's not enough data to show that this is actually a useful endeavor for most of our patients. However, most likely there are certain patients that would benefit from something like this. And that brings me to plasma exchange. So therapeutic plasma exchange is most often used in the critical illness setting in patients with multi-organ dysfunction, especially those with thrombocytopenia, as well as evidence of coagulopathy and DIC. And the thinking behind this immune modulation is that if you remove all of the ongoing cytokines, but in addition, all of the activated coagulation proteins, and rebalance your immune system and your coagulation system with fresh, healthy plasma, replenish ADAMTS13, replenish tissue factors, all of that could improve your clinical outcomes and decrease the immune dysregulation that's ongoing. And as early as 2011, even in a very small cohort study with Dr. Carcillo, this was shown to have some improvement in most of the patients' clinical outcomes. In addition, there was some benefit shown in a more recent trial with sepsis, adult sepsis patients who either received heparin, no heparin, or plasma exchange, or plasma exchange without heparin. And the plasma exchange group did have an improvement in mortality. And so potentially there's something here to a specific population of patients, specifically those with either DIC or coagulopathy, could benefit from a therapeutic plasma exchange. We obviously use it as first line for TTP and often Guillain-Barré syndrome. It's used as a second line adjunctive for graft versus host syndrome, and there's several other autoinflammatory and immune-mediated diseases that we at least talk about, if not start to use plasma exchange. And again, there was a recent meta-analysis that just came out in 2023 that does show overall that there's likely a small or a significant but small benefit with mortality using therapeutic plasma exchange in adults. Shifting gears for a minute, just to talk a little bit about what I think is an important mechanism of antiviral response, since at least in the pediatric ICU, many of the patients that we see start with viral illnesses, especially respiratory ones. Viral respiratory infections cause secretion of type 1 interferon, so interferon alpha, beta, and several others, as opposed to the interferon gamma that's secreted by T cells. And this causes not only an inflammatory response, but it mediates the antiviral milieu of the tissue, and it helps eradicate the virus locally as it's secreting, as it's stimulating the rest of the innate and the adaptive immune system. However, it's known before COVID, but really came out in COVID, that several severely ill adults with COVID did not produce the amount of either interferon alpha or beta that was expected. And there were several studies showing that some of these patients have inborn errors of type 1 interferons, which they had never known about before, and they were completely asymptomatic before, but this particular virus triggered them to not produce type 1 interferons. There were also patients that had autoantibodies to type 1 interferons, and those patients not only had decreased eradication of the virus, but they also had increase in inflammation, because there was ongoing persistent secretion of IL-6 to try to manipulate the immune system to increase the inflammatory response, because it wasn't blocked by the pathogen eradication or the viral eradication with type 1 interferons. And there were several studies that didn't necessarily show clinical outcome improvements, but there was a mortality improvement when administering type 1 interferons to these patients. Some were inhaled and some were systemic, in order to try to manipulate the antiviral effects of their immune system. And so understanding where the immune defect is and then trying to manipulate post that defect could be a valuable way of managing patients with severe illness in the ICU. And of course, we talk a lot about patients that develop HLH, and secondary HLH could be a patient who is genetically predisposed but doesn't have necessarily the genes specific to congenital HLH, but they could respond poorly to a viral or bacterial infection and have this overwhelming inflammatory response. Now, the interesting thing here is that the inflammatory response is because of a defect in the negative feedback loop from cytotoxic CD8 T cells and natural killer cells. And there's an overproduction of interferon gamma, TNF alpha, IL-1 beta, IL-6, as well as uncontrolled macrophage phagocytosis. And so treatment here goes down that same pathway that we think about with several other of the diseases that we've talked about. You think about steroids, you think about blocking specific molecules like anakinra or tocilizumab to block IL-1 beta and IL-6. But you can also block interferon gamma, which is that positive feedback to tell the macrophages to continue to go and to tell the other cells to continue to secrete cytokines. And so using something like emapalumab, which blocks interferon gamma, has been shown to really downregulate the inflammatory response in patients with HLH. You can also use your JAK inhibitors, as we talked about, and block natural killer cells, which is one of the cells that is overexpressed. And then, of course, using chemotherapies to destroy all of the immune cells that are causing secretion of cytokines if nothing else is working. The superantigen theory is something that I'll just touch on really quickly, but there are molecules that are secreted by various pathogens, but mainly Staph aureus and other staphylococcal bacteria that don't bind to the T cell receptor specifically, but bind around the T cell receptor and can therefore activate T cells that are not specific to the antigen from Staph aureus, and it could activate up to 20% of your T cells. And so if this theory holds up, then you can really have an auto-inflammatory process from these molecules by them bypassing the T cell receptor and activating many T cells within the response. And again, we don't have a specific therapy at this point, but there's a lot of research looking at how to downregulate that response. So that was a lot about how the innate cytokine response can produce an auto-inflammatory or a hyperinflammatory milieu in or systemic inflammation causing tissue damage. Now we'll talk a little bit more about the adaptive immune system for a few minutes, as well as cellular immunity. And so when you have an adaptive response, you have, as we said before, cells migrating from the area of infection to the secondary lymph tissue to activate naive T cells or naive B cells to form highly specific attackers against the infection or against a specific injury. B cells actually go through several different processes, and I think it's just interesting that the first process that B cells undergo is just clonal expansion of whatever B cell is activated. And that sometimes will have specific antibodies, but not the most high affinity. And afterwards, it undergoes several more stages of mutations to really hone in on the most specific high affinity antibodies. And so it can really have a high efficiency response later in the infection, but a much more high efficiency response for subsequent infections. And the reason this is interesting is because in situations where there's high inflammation, sometimes some of the checkpoints can get lost. And some of those checkpoints are what's stopping B cells from producing autoantibodies. And so in a large infection where you have increased inflammatory response and hypercytokinemia, that might be the situation where there's also unchecking of some of these checkpoints, and you develop several autoantibodies. And that's one of the hypotheses behind diseases like MIS-C, where the inflammatory response and the immune response to COVID in some of these naive children, or naive meaning that they haven't seen COVID previously, then their B cells start to replicate and they start to mature and mutate, but they sometimes will miss some of the checkpoints and create low specificity, low affinity, but self-antibodies to various other organs like the myocardium, vascular endothelium, and cause problems as those B cells start to proliferate. And so we use IVIG as a therapeutic for several different reasons, but one of them is to downregulate an autoantibody or an autoimmune response. Diseases like Kawasaki disease, ITP, Guillain-Barré syndrome, MIS-C. There's thoughts and theories about using IVIG to trick some of the receptors into not responding to the self-antigens, to overwhelm the system, to decrease the autoantibody response, and to block some of the downstream pathways like the complement activation, macrophage activation of some of these autoantibodies. We also sometimes use IVIG just because patients with critical illness are deplete in antibodies. They'll have low IgG levels, low IgM levels, either from decreased production, B cell apoptosis, or third spacing of fluids and shifts of proteins into the extravascular spaces. And so sometimes using IVIG just to augment the immune system in a patient who's critically ill because they don't have the humoral antibody response that they necessarily should have. So with the last few minutes, we'll go through a few more ideas in how we can modulate the immune system and thinking through some of the immune exhaustion that we talk about a lot. So what is immune exhaustion? And so you have resident cells in the tissue, like macrophages that sit there, dendritic cells, natural killer cells, but there's also innate lymphoid cells. And those innate lymphoid cells sit in the tissues and they can be activated and they help activate T cells and B cells. But sometimes those cells polarize and shift towards their anti-inflammatory or their immune suppressive and immune regulatory phenotypes. Macrophages can go from the M1 to M2 phenotype. Neutrophils can start to either degranulate and express several what we call nets, neutrophil nets, into tissues and cause local inflammation but not function properly. Dendritic cells and macrophages will lose their abilities to present antigens to T cells. And the question is, why does that happen? And so I'll skip this for a minute, but you can think about how cells need to undergo apoptosis so that the antigen presenting cells can recognize some of these molecules and then bring them over to the lymph nodes to activate T cells. In order to do that, there needs to be co-stimulatory molecules as well. And co-stimulation is required because we don't want just ongoing, unbridled T cell activation. We want a controlled and balanced T cell activation. And so as more T cells become activated, they express less of these co-stimulatory molecules like CD40L, CD28. But a lot of these molecules are expressed as T cells become activated. And if there's ongoing inflammation, then it downregulates. There's also new molecules that are expressed instead of the co-stimulatory molecules, which are called counter-regulatory molecules. And these are cell surface molecules that block activation of T cells. So there's molecules like PD-1, LAG-3, CTLA-4, and TIM-3. These are all molecules that if a T cell that expresses high amounts of this is activated, it stops it and it says you can't continue to activate because there might be ongoing inflammation. And this really needs to be well balanced in order to augment an attack, but not have too much or too little immune response to whatever the stimulus is. And at the same time, as there's shifts in the activation of T cells and shifts in the polarity of macrophages and neutrophils, you have expression and secretion of cytokines that are more immune suppressive and less immune inflammatory or less immune activating. Molecules like IL-10 and TGF-beta often will downregulate some of those responses to keep things at bay, but if they're overexpressed, then you have a more suppressive phenotype instead of a balanced phenotype. We also know that over time, or early in infections, when there's high inflammation, there's also a lot of apoptosis that undergoes. There's also necroptosis and pyroptosis, which are other controlled cell death mechanisms that can also recruit neutrophils, recruit macrophages to the site of infection. And they are ways to elicit a controlled inflammatory response to a stimulus. But with cellular depletion comes decreased orchestration of a balanced attack and decreased ability to fight whatever the stimulus is. What we see is that with this change in immune response, there's decreased antigen presentation. The MHC class II molecules on monocytes, macrophages, dendritic cells downregulate, so they're not able to respond as efficiently as they once were. You have overexpression of myeloid suppressor cells, or MDSCs. These are cells that are pumped out of the bone marrow when there's an infection, but they're immature. And they don't know if they're going to be neutrophils or monocytes. They just come out as either somewhat granulocyte MDSCs or somewhat myeloid MDSCs, and they have a suppressive phenotype. And patients have been shown who have elevated numbers of MDSCs to have poorer outcomes, especially later on after infection or after trauma. And there's a lot of work being done right now, nothing that is actionable in terms of use in the ICU, but there's a lot of people who are working on ways that you can target MDSCs or target other immune suppressive cells to downregulate them to allow for better response. And these are things that are actually used in cancer immunotherapy to decrease the MDSC numbers in order to allow for T cells and monocytes to have a normal, efficient, balanced response against the tumors. And one way to understand how immune cells become dysfunctional is you can take cells from a patient, and there are several different ways to do this, and stimulate them with either T cell receptor stimulations or monocyte stimulators, toll-like receptor stimulators, and see whether or not they produce the cytokines that they're supposed to. And the patients that don't, as we've shown in some of our work, as well as Mark Hall's work at Nationwide, and the group at Penn State here has shown that downregulation in the patients of in patients who do poorly in the ICU after sepsis and traumas have decreased response to stimulation after you take the blood out of the patient. And so that's a really nice way of showing that these patients have more suppressed phenotypes and need to be augmented in order to fight the infections properly. And so what can you do? You can look at some of the growth factors and the stimulating factors that that augment the immune response in the first place. And so we often will look at GCSF or GM-CSF to stimulate neutrophil and monocyte productions, giving patients interferon gamma to activate the T cell response, or IL-7 to promote T cell proliferation and growth. There's not a lot of great data that shows that any of these in large populations work well, but in the right patients, in patients who are either neutropenic or have low monocyte counts or low or lymphopenic, perhaps some of these can work really well. And so there's definitely ongoing studies looking at IL-7, GM-CSF, and sepsis. And the key is to figure out which patients do best with one and which patients might do better with another to re-stimulate the immune system. Another molecule that is used in some countries, but we still don't have access to and probably don't need to, is thymosin alpha-1, which is another T cell stimulator that is endogenous to the thymus. And what this does is it promotes proliferation and activation of T cells, differentiation, maturation into different T cell subtypes, and helps activate antigen presentation natural killer cells. Still not a lot of great data in terms of whether or not there's mortality benefit in sepsis. This was studied a lot in China and other countries in COVID-19. But another way to think about upregulating the response for the body to produce more T cells and to activate them in an appropriate fashion. And finally, or almost finally, sorry, trying to downregulate some of these counter-regulatory molecules. So there are several drugs that are used in cancer and have been looked at in sepsis and other critical illness states, blocking the PD-1 receptors, LAG-3, CTLA-4 has drugs that are used throughout different cancers and downregulate the suppressive or the exhaustive molecules, therefore upregulating the activation of T cells. Finally, how do we use the immune system to attack the specific pathogen in an infection? So in COVID, we often use convalescent plasma. We took plasma from patients who had just recently had the infection, who have produced a lot of antibodies, and gave that to patients who are sick to see whether or not that can augment their immune response. We can also manufacture specific antibodies. We do this in botulism, other poisonous venoms. We've done it with COVID, where you give patients passive immunization or secondary prevention to try to beat the infection by manufacturing these antibodies. There's now several groups that are using adoptive cell therapy. A lot of immune suppressed patients, they'll be able to take donor cytotoxic T cells that are specific against adenovirus or herpes viruses, cytomegalovirus, EBV, and proliferate them in the lab in order to expand several of these attacking T cells that are specific to a virus, and then giving it to a patient who is suffering from a virus that their immune system is incapable of eradicating. And so these are really new and interesting therapies that are probably more up and coming, still used mostly in the immunosuppressed, the oncology patients, but can start to, at some point, make its way into the regular ICU. And we don't have a lot of information or data about this, but there's clear benefits to good nutrition to patients over their hyperacute phase, early mobility, allowing muscles to continue to grow. All of these things will help augment the immune system because it allows cells to regulate themselves and be back to their normal function, normal transcription of proteins, their better epigenetics. And so there's a lot of reason to believe that this would be helpful to patients, and it's things that we're already doing in the ICU. So the future for immunotherapy is ultimately precision immunotherapy. It's understanding the specific defects in patients who are critically ill, understanding whether or not there's something that we can do to manipulate the immune system in order to either downregulate hyperinflammation or upregulate a suppressed and exhausted cellular immune response. And that's where I'll end. I just want to thank my mentorship group and the lab that I work in. And I don't know if you wanted Michelle to move on to the next one and then have questions at the end.
Sounds good. Thank you, Dr. Mazur. So to just reiterate that if you guys have any questions along the way, please include them in the chat. And I just wanted to call out Dr. Bloomberg. He wanted to make sure that everyone knew about the immune dysregulatory effects of blood transfusions there in the comment. I wanted to thank Dr. Mazur for condensing a super broad topic and then talking about all the upcoming therapies in a very short span of time. We can ask more questions in the Q&A, but next I'd like to introduce Dr. McAvoy. She wears many hats at WashU St. Louis. So she is an associate professor in division of pulmonology and critical care. She's also the director of stem cell transplant and the ONC ICU. She also is associate director of the PH program there. She's going to be talking to us about cellular therapies and then cytokine release in the ICU. I'll hand it over to you.
You're muted.
You'd think I'd know by now how to do this, right? We'll get there. But so thank you very much for having me. This is a slight twist from what we were just talking about, but I think it's really an important topic. You know, I'm pulmonary critical care, yet I've learned a lot more about the immune system over the years, particularly as we have been advancing in these novel cellular therapies and how it applies to how we take care of patients in the ICU. And I think we've gained a lot of information about these toxicities that have now become related more to other disease states that we see in the ICU, like COVID. Cytokine release syndrome really got a lot of press during COVID. But I first knew it during the CAR T. So that's what we'll focus on here today. I have no disclosures. We'll review cancer immunotherapy, not to overlap from what we just heard, but just specific to cancer, and then talk about CAR T cells and other immune effector cell therapies. What are their products and indications? And then briefly discuss CRS and ICU management. So really, what is immunotherapy? And we talked a little bit about this, but the cancer immunity cycle, I think, is fascinating, where the T cell is supposed to recognize cancer cells as non-self, and then it destroys them. But what cancer cells have done is they start to immune edit. So they have ways to avoid detection by our innate T cells. And so as a result, then the cancer proliferates and patients have cancer. So what immunotherapy does is it uses medication to facilitate our own body, so activating our own immune system to allow uncovering or exposing of these T cells so that we can then kill the tumor cell. It has become one of the pillars of our anti-cancer therapy, along with surgery, radiotherapy, traditional chemo, and precision therapy. We think about it with checkpoint blockade and then adaptive cell immunity, which is what we'll focus on. So what happens is you isolate the immune cells from the patient or from a donor through ex vivo engineering. Then the cells expand and then reinfuse into the patient. And the CAR T cells, so chimeric antigen receptors, are synthetic receptors that are engineered on these immune cells with different structural components based upon what they need those structural components to recognize a specific protein on the cancer cell and deliver this activation signal, which then allows the cancer cell to die. So since that came about, we think about all the different types of cellular therapies. And again, the goal is to really use our own immune system to sharpen and strengthen it to then fight the cancer. So you have the chimeric antigen receptor CAR T, and then you have natural killer cells. Those are cells that are part of the immune system's first line defense, usually against infection and disease. And these trials are underway. along with engineered T cell receptors or TCR therapy. It allows it to kind of hook on to these specific target proteins on the tumor cells, and then tumor infiltrating lymphocytes that use T cells from the patient's actual tumor, and then they reinfuse them back into the patient. So these are some therapies that are considered immune effector cell therapy that are underway. But again, today we'll talk about CAR T. So what happens with the CAR T cells? So initially, they apheresis from the patient, and typically from the patient. Most are autologous, but there are some like off the shelf allogeneic. But for the most part, we have autologous CAR Ts that then have some selection and activation through expansion. And then they use a gene transfer with a viral vector, and again, expand, and then they wash and then reinfuse back into the patient. It's considered a living drug because it has durable destruction of the malignant cells, because what it's doing is redesigning the T cells in the body to then attack these tumor cells. So different than chemotherapeutics, which is targeted medication to just kill the cancer cells, this is using your own T cells to then continually kill the cancer cells. So it's this living drug. This is just another schematic of what it looks like. So removing the blood from the patient, they make the CAR T in a lab, they grow millions of cells, and then they infuse the cell back into the patient. Prior to infusion of the CAR T into the patient undergoes conditioning regimen to deplete the patient of some of their own cells to allow for uptake of the CAR T cells. So patients are neutropenic at the time of CAR T infusion. The other thing to note is that when they're growing these cells, the oncologist can tailor based on what they need for the patient and what type of malignancy they have, how many cells are actually infusing into the patient, which can then influence the amount of toxicity that occurs based upon these CAR T cells. So now there are 6 FDA-approved CAR T cells, which is really exciting. And Kymriah was the first that was approved. It was improved in B-cell ALL in children and young adults for refractory and relapsed B-cell ALL. And then if you look through this list here, what you see is that patients are relapsed or refractory. So these are patients that have undergone 3 or more lines of chemotherapeutics prior to receiving their CAR T. So these are patients that have gone through a lot, and yet they still have significant response. So this is why it's so revolutionary, is that all of these lines of therapy have failed, yet patients have had up to a 50% durable response related to the CAR T. What is also important to note is that over the last couple of years, there have been 2 new products that have been approved for multiple myeloma. Multiple myeloma is one of the more common forms of malignancy. And so we will start to see a number of patients receiving these CAR Ts coming into all ICUs across the country with toxicities related to CAR Ts. So I think as we continue to expand, we're going to be seeing more and more patients. These are just the only FDA approved, and they're approved more for the heme malignancies. Right now, there are over 200 trials in heme malignancies for CAR T or immune effector cell therapies. And then there are over 70 trials right now in solid organ tumors. So again, we will be the front line in seeing some of these toxicities that come into the unit. So what are those toxicities? Well, the main one is the cytokine release syndrome. Immune effector cell associated neurotoxicity syndrome, or now called ICANS, is another one that is incredibly common. We won't go into detail today, but certainly something to continue on your radar and to read about. Tumor lysis syndrome is less common, but certainly can occur. Macrophage activation syndrome and HLH can look like an overlap with cytokine release syndrome, but in the most severe of forms with an incredibly high mortality rate. B-cell aplasia and hypogammaglobulinemia are more on the later term toxicities, and we're starting to see patients coming back after surviving CAR T and doing very well with hypogammaglobulinemia and having recurrent infections, as we just discussed about how our innate immune system really needs to be protected. Otherwise, they'll continue to have recurrent infections. And so that is now a significant cause of morbidity and potentially mortality in these patients. So CRS is a clinical syndrome. It's really a supraphysiologic response. I like to think about it just as an overall storm, and that's what we've talked about as cytokine storm. And I love this visualization of CRS because that's exactly what seems to be going on in the patient's body. The prevalence really depends upon the malignancy and the CAR T construct, but occurs in the majority of patients, so 60 to 90% of those patients, whereas about 15 to 30% will have greater than grade 3, which is a fair amount of patients, and about 20% of those going on vasopressors. It depends also on the tumor burden and that higher cell dosing, like we talked about earlier. It usually appears within 7 days, but can be up to 10 weeks. And it depends also on the CAR T construct. Some of the newer agents, CRS, will appear within the first 1 to 2 days. And so making sure that you have good discussions with your oncology team about this specific CAR T product is incredibly important. So the physiology really goes back to what we were just talking about. It's all of the activation of our T, B cells, NK cells, and macrophages that causes this overall inflammatory response that leads to increased CRP and ferritin, TNF gamma, TNF alpha and interferon gamma, IL-6 and IL-10 are some of the major mediators of this response. We know that those that have high severity of CRS have higher CRP levels and higher pro-inflammatory cytokines. Most centers do not measure the pro-inflammatory cytokines outside of a clinical trial, but since COVID, IL-6 measurements have become more common at some centers. We also know that higher SOFA scores are associated with TNF alpha and increased interferon gamma levels. We utilize CRP really, though, as our biomarker for diagnosis. Hopefully, we'll be able to tailor that a little bit more, as we know that CRP can be very nonspecific and does not help us really differentiate between CRS and sepsis well, which we'll talk a bit about here in a little while. This is really just taking a look at all of the things that we've discussed. What happens when you have binding of your CAR T to the macrophage? You have increased nitric oxide production. You have continuing circulation of the monocytes, which then leads to pro-inflammatory cytokines like your IL-6, IL-1, and NO. And this is where you start to see some of your physiologic effects of vascular leakage, hypotension. And this is one of my favorite schematics. I'm sorry it's coming out a little bit blurry, but this goes to the point of when you see interferon gamma and TNF alpha, it causes this flu-like syndrome. So fever is the mainstay of CRS, but you get fever, fatigue, headache, myalgias, rigors. You can then develop hypotension, can cause acute kidney injury. And then as we go on to have continued activation of our macrophages and monocytes and dendritic cells with increased cytokines, that's where you see the more severe forms of toxicity, including cardiac toxicity, coagulopathies, DIC, neurotoxicity, the ICANS, which can be manifested from just word difficulties, some aphasia, confusion, can even advance to paralysis, cerebral edema, seizures, and status epilepticus. And from the pulmonary standpoint, we see vascular leak, non-cardiogenic pulmonary edema, and ARDS, and significant hypotension requiring vasopressors. This is looking at the patient's time frame from when we start to see different manifestations of the CAR T. So they undergo their conditioning regimen, which is typically fludarabine and cyclophosphamide for conditioning regimen. They receive their CAR T infusion. They start to see some of these cytokines develop, and early on you'll see CRS. The major thing to note is that you have an overlap between cytokine release syndrome and neurotoxicity. Cytokine release syndrome and acute neurotoxicity, again, can overlap, but as neurotoxicity becomes more in the later stages, it really does seem to be a separate entity. And we do not treat it the same way as we do when there's concomitant CRS and ICANS. A lot of this is related to the proliferation of the CAR T cells in the peripheral blood. And it does cross the blood-brain barrier. So here are all the manifestations that you can see. The three features, though, to determine severity of CRS are related to fever, hypotension, and hypoxemia. Early on, there was different grading systems, but now we go by fever, hypotension, and hypoxemia. But as you can see, it affects all organs of the body. You can have dysrhythmias, cardiomyopathy, heart block, shock, capillary leak syndrome and ARDS, GI disturbances, hepatic failure, acute renal failure, DIC. Skin lesions are rare, but Stevens-Johnson syndrome has been described. So what are the risk factors? So a high disease burden, like those in ALL, high infusional dose, if you had fludarabine-containing lymphodepletion, concurrent infectious illness, which makes sense. You're already driving up your cytokines. And here at our institution, we screen for viral illnesses with a respiratory viral panel multiplex prior to infusion of CAR T. You can have early cytokine elevations that again correlate with severity of disease or of toxicity. Oh, sorry. So this is the grading system by the American Society of Transplantation and Cellular Therapy that we are now have adapted over the last few years. Again, it mainstays fever. You do not have CRS if you don't have fever. So no CRS if no fever. I try to teach our residents that, but always something to remember because patients still can be quite sick from other reasons, and you have to exclude other causes and look at their comorbidities when they present to the ICU. Hypotension, so again, we see these typically when they come in at grade 3 or grade 4 because they're requiring vasopressors, and then the hypoxemia as it progresses. This is a group of us that are part of a CAR ICU initiative, which is 11 academic centers that treat patients with CAR T cells. And what we did is we were looking at patients who received Yescarta that were admitted to the ICU. And this is 105 patients over a course of 11 centers. And you can see that about 65% of patients had grade 3 to 4 toxicity came to the ICU. During their ICU stay, 77% developed CRS and 85% had ICANS, so quite high. And 61% of those had both toxicities. About 20% required vasopressors, which goes along with the previous literature from clinical trials. These are patients that were outside of clinical trials, so real world data. And their days on vasopressors was quite short in comparison to patients who have septic shock. Still had about 10% of patients who required respiratory support, whether that is invasive mechanical ventilation, high flow oxygen, or non-invasive mechanical ventilation. And about 3% required renal replacement therapy. The ICANS showed 20% had seizures, with about 6% at status epilepticus and 8% was cerebral edema. So again, can be quite severe and life-threatening. This is the specifics of the CRS, whereas again, it all should have been fever, but about 50% had hypotension, about 30% with hypoxemia. And symptomatic arrhythmias, cardiomyopathies, pleural effusions were quite common, and hepatotoxicity was also quite common. This is looking at overall survival of about 10 months. Now, again, when we look at overall survival, many people that I've talked to outside of those that treat CAR T patients think 10 months is not that long. Well, these are patients that were relapsed and refractory and really had no other lines of therapy and were otherwise going to die. So 10 months is actually a really impressive amount of time. And again, why we find this to be a really fantastic therapy despite its toxicity profile. So management of CRS. each institution really comes up with their own set of guidelines, which is a little bit unfortunate because we don't have a national set of guidelines for how to treat CRS. But really the mainstay is tocilizumab and IL-6 and corticosteroids. Other considerations are with anakinra, and I'll talk a little bit more about all of these here in a second. So we looked at really essentially something similar on the last lecture, but what you have again is you have your cancer cells and your CAR T cells, and you're developing all of these cytokines and activation of monocytes and macrophages, which just continue to have more inflammation. And so what are we trying to do? Well, you're trying to block IL-1 and block IL-6 so you don't have all that inflammation. Because there is no set of guidelines, what we decided to do is with this group is take a look at how do we practice and what are people doing. So 82% of those of us had experience with commercial and non-FDA approved products, so those that are in clinical trials, which is different than our previous study. 100% of those were admitted for grade 3. So we're looking at when do patients actually come to the ICU, and grade 3 really seems to be the main cutoff. Some other centers, it was a little bit earlier, which is fine. Early ICU admission for close monitoring is certainly recommended. And we saw that there was really no difference in vasopressor support, neurotoxicity, and EEG monitoring, and use of prophylactic anti-epileptic drugs, which was at grade 1 of ICANS. And then the use of tocilizumab was comparable. But what we did find that was different was the varied fluid resuscitation, which is not surprising to any intensivists out there, respiratory support, use of corticosteroids and other anti-cytokine therapies. So if we look at this, the dose of corticosteroid varied amongst the institutions, which is why I did not post like our algorithm, because everyone's algorithm is slightly different. Typically, we reserve really high doses like prednisolone of 500 milligrams Q12 for grade 4. Other centers did use it at earlier grades, but we tend to use it at grade 4. The other rescue therapies, so ATG, suicide genes, which is typically in clinical trials. And then if we look at ruxolitinib, so a JAK inhibitor, infliximab, and basiliximab and cyclophosphamide have also been used. Anakinra was used in about 55% of patients, and I'll give you a little bit more. This is not a significant number, so just 6, but there is another study looking at 43 patients that had use of anakinra for those that had prolonged CRS or ICANS, and they looked at the difference between low and high dose. High dose was defined as greater than 200 milligrams per day, either IV or sub-Q. And what they found when these were in patients with a B cell or plasma malignancies, that these doses were safe, and that the higher dose may be associated with a faster CRS or ICANS resolution and lower TRM. And so anakinra has really been adopted by most centers for use. Again, though, the dose and frequency still varies per center when you talk to other folks. So other possible therapeutic interventions, similar to what we were talking about with anything in the ICU, we're trying to prevent this overall hyperinflammatory phase and targeting similar agents. None of these have been, besides tocilizumab, have been approved for treatment of CRS, although anakinra is being really adopted at most centers, but does not have a FDA indication as of yet. One of the big things to discuss is whether or not we have CRS or sepsis. It's very difficult to tell the difference between CRS and sepsis, but we know that in these patients that are neutropenic and immunocompromised, they've undergone multiple lines of chemotherapy, infection can be quite common. So it typically occurs between day 0 and 90 when we're looking at it for whether or not it's CRS or sepsis. CRS can go out to about 10 plus weeks. But this was a group looking at the number of infections. Most of the time, though, 80% of those infections occurred within 10 days after infusion. And I told you that CRS occurs early on, so it can be very challenging to differentiate, which is why treatment with empiric antimicrobials is incredibly important early on. We know that if there is an infection, that an hour delay of antimicrobials in septic shock increases mortality by 10% per hour. And what we're seeing is that about 40% were severe and 4% had life-threatening or fatal infections. One thing that I find incredibly important to note is that about 4% had invasive fungal infections. It's one thing that we need to really keep in mind, because it's easy to think about covering empirically with our antibiotics, but making sure that we're covering for invasive fungal infections is also key in this patient population. Interestingly enough, when they looked at this study, CRS severity was the only factor associated with infection. So 28 patients had both CRS and infection. And you may say, well, how do you know if it was CRS or if it was infection? The people in the trial were looking at CRP levels. Again, it's inherently flawed, but based on timing, it still makes sense that it may have been CRS. So another study looking at infections, so these were in B-cell ALL, and again, 42% experienced infections within the first month. So keeping that high on the differential is vital. And grade 3 CRS or higher was independently associated with increased risk of subsequent infection. Interestingly, during COVID, when tocilizumab was being used more frequently, there was an association with higher incidence of infection, particularly fungal infection, in those patients with COVID that received tocilizumab versus those that did not. And here in this study, 6% died from an infection-related cause. So best practices is really looking at early ICU admission, making sure that you're treating your respiratory insufficiency as you normally would treat with antibiotics, intubation, mechanical ventilation, rule out infection or alveolar lavage based on, or alveolar hemorrhage based on your bronchoalveolar lavage, lung protective ventilatory strategies, making sure that you have availability of IL-6 inhibitors. That became a big discussion at our center during the height of COVID when IL-6 was being utilized, to make sure that we had enough IL-6 or tocilizumab for our CAR T patients. And then constantly reevaluating and whether or not you can de-escalate steroids or anti-IL-6 therapy with discussions with your oncologist, and making sure that you rule out alternative diagnoses. So what does this mean for the intensivist? Well, if the majority of patients require ICU admission, if you kind of calculate just for lymphoma patients, that means that at least 14 to 44% of CAR T patients will require critical care. And this is just for ALL. This doesn't even take into account multiple myeloma. So at some point you will see a CAR T patient coming through your ICU with complications. So moving beyond CAR T therapy, we talked a little bit about some of the other immune effector cell therapies, but why are we trying to move beyond CAR T? So I told you that CAR T seems to be working really well as far as for treatment of the cancer, but with this side effect profile, it can be hard. It's also very time consuming and expensive. It uses mostly autologous cells, and it can be very expensive to do that. You also over time can have antigen loss, and then that decreases the effectiveness of the CAR T. And then if you did use off the shelf, so allogeneic, there's a potential for GVHD. So it is expensive, it comes with a side effect profile, and it can potentially have GVHD if you use allogeneic. So what does this mean again for us? Those that are in immune effector cell trials may reside in the hospital for 2 to 3 weeks for continuous monitoring. And that requires a high level of coordination, quality control, and a multidisciplinary effort to take care of these patients. And clinical trials for immune effector cell therapies, I highly advocate that we have input from intensivists for this. We need to understand the complications related to CRS, ICANS, high-dose IL-2 related toxicity that's used in some of the tumor infiltrating lymphocyte studies, and the myelosuppression that occurs in all these patients from conditioning regimens. So I think that there's going to be more and more to come as we start to see immune effector cell therapy, not just for heme malignancies or solid tumors, but even in our autoimmune conditions, and potentially, who knows, maybe even in sepsis. So that, I think, is one of the big things. So we need to keep calm and be ready overall. Things to think about, this is just how to deliver CAR T safely, is making sure that you have a fit and stable patient, that there's psychosocial support. These patients are in the hospital for a long time. Again, they've already been deconditioned related to their prior therapies. Knowing who to call, staff education for our nurses, for our provider team, and then how to manage this, and then what is the oversight for making sure that we have the appropriate therapies and guidelines to treat these patients. So thank you very much. I appreciate your time.
Thanks so much, Dr. McAvoy. I think this leads us into our Q&A.
Thank you, Dr. McAvoy and Dr. Mazur. So any questions before any questions I'm trying to see here in the chat? I don't see. Okay. Michelle, can you talk about the time to initiate? I think you did already there. Okay. I think you talked about most of these. Michelle, is there something lingering with your question by chance?
No, I was typing and then she answered all the questions.
Good.
So, Colleen, one question for you is the longevity of CAR T, and so there's a lot of work being done right now to try to use immune adjuvant therapies to try to increase the longevity of CAR Ts, whether that's with IL-2 or IL-7 or even interferon gamma at the time. Do you have any experience with that so far? Have folks like yourself or John DePerzio or other folks been doing that right now? And do we think that that's a promising way to make sure that the longevity for these adoptive cell transfers actually remain?
So outside of a clinical trial, I have not seen that through our BMT group with DePerzio coming through the unit, but I know that they have trials underway. There's also, they're utilizing also JAK inhibition as well to try and help with longevity of the CAR Ts. And so luckily, we haven't seen patients come to the ICU related to that. IL-2 does give me pause, depending on the dose of IL-2. So for those of you, there's low dose and high dose IL-2. High dose IL-2 that's using like tumor infiltrating lymphocytes will create that vascular leak syndrome that leads to kind of the capillary leak and overall kind of decline that we see in the unit. But if you use low dose, it actually can cause, as Dr. Remy's talking about it, it can help with the immune system kind of suppression wise. So we haven't yet. So I don't know if that really answered your question.
No, that's fine. Any questions from the audience? Either write them or raise your hand, and we'd love to hear from folks here. I'm looking here at the audience and no hands raised. Okay. Dr. Mazur, question for you. So given the fact that away from CAR T for one moment, just talking a bit about some of the work you're talking about in sepsis, especially in children and in adults, one of the things that we're really good at is deploying steroids for CIRSE and other indications, but certainly the negative consequences of steroids perhaps could have deleterious effects for many different patients, especially if they're already immune paralyzed, if you will. How do you think we're going to have to refine these? Is there ways that we're evaluating this that you think would be helpful? And so that we can refine the population and less of a heterogeneous population and try to make endotypes that we can perhaps look into this with adults and kids.
Yeah, thanks. That's a great question. I think, now that we are slowly starting to uncover mechanisms, and there are just so many papers that are being put out on a weekly, monthly basis, trying to elucidate mechanisms in immune dysfunction. And then the real goal is trying to figure out a way that we can take those mechanisms and learn about them on short order in our patients in the ICU and actually make a clinical test about it. And so, there's several tests that are already readily available: cytokine levels, proliferation assays that we use in oncology can theoretically be used. Stimulation assays are being used in many clinical trials right now to try to understand immune response and whether or not there's an exhaustive phenotype. But I do agree with you. I think that the two things that are going to happen is over the next decade, we're going to understand better about the phenotype of the patient quickly within clinical tests, and we'll be able to follow them over time and see how the dynamic changes of their immune response differs over the course of the first several days of their illness. That'll be one, but the other one will be we'll understand so much more about the targeted immunotherapies that there will be so many more few times that we'll have to reach for steroids as the answer to the question that we're trying to ask. And so using steroids is a great way to downregulate the entire inflammatory and immune response. However, it puts you at risk of infections, and it puts you at risk of adrenal insufficiency and bone mineralization issues. And so I think using something like high-dose corticosteroids is going to continue to decrease in utilization as we better understand the mechanisms and have targeted therapies.
Any other questions from the audience? Dr. McAvoy, I do have a question. So one of the things that's quite interesting, certainly in the oncologic patient population, is that there's a little bit more of a liberalization for transfusion practices in that population. Is there any thought perhaps that, and I see Dr. Bloomberg on here, so I'd love to hear his thoughts too. But is there any thought perhaps that donor-specific characteristics in transfusing patients that have received CAR T may in fact influence the development of things such as CRS and ICANS?
I mean, it's an incredibly good thought. I haven't seen anything in the literature that's related to that, to know if the number of transfusions does increase the incidence of the toxicity. Dr. Bloomberg, would also love to hear your thoughts on that as well.
Well, they're mostly a form of hand waving at this point. I think the best way to summarize it is that allogeneic transfusion is a little bit like an allogeneic organ transplant, a stem cell transplant, but it's temporary because we're mostly transfusing, differentiated cells, but that doesn't mean that they're not immunologically active. Evolution has provided us through mammalian pregnancy with a model for what happens when you give partially self and partially not self intravenous antigen, and it's not good for your immune system. Women who are pregnant, as we all know, have a slightly increased risk of certain malignancies and a slightly increased risk of certain types of infections. And with transfusion, that's augmented by the fact that the stored blood cells are highly dysfunctional. Platelets are activated, red cells are also biophysically and biochemically abnormal. So the short version of this is transfusion is prothrombotic, and as mentioned by Dr. Mazer, for other types of stimuli, it's dysregulates innate immunity, so you have inappropriate inflammation, and it downregulates cellular immunity, particularly T cell immunity, which is one reason that helped you accept allogeneic kidney transplants. So our work in particular has focused on things we can do in the laboratory to make transfusions less toxic. We've got randomized trial data in pediatric cardiac surgery that if you wash transfusions and remove the supernatant of microparticles and God knows what else, membranes, you can reduce inflammation. Not many blood banks are happy about washing any kind of blood cells because there's a long-standing, non-data-driven skepticism about that. We've also shown that removing the stored supernatant of platelets seems to reduce the immunotoxicity of transfusions to acute leukemia patients. So I think the future here is, as Dr. Remy mentioned, one, understanding the mechanism here so that you can perhaps pick donors better, and also, if we're correct, and I think we are, modifying the transfusion to be minimally immunotoxic. And I think and it's just my impression and no data, or we need to look at it, that we've seen less CRS and less bleeding in our patients with CAR T-cell therapy. And part of that, I think, is not giving ABL mismatched platelets, which is a longstanding dogma in transfusion medicine and hematology. The ABL matters for red cells and organ transplant, but it doesn't matter for platelets, which in retrospect makes no sense. But that we now have data that ABL mismatched transfusions, which your blood bank is probably providing you with in many patients, may increase inflammation and increase bleeding. So there are going to be a whole bunch of strategies. A very long answer, I realize. I do apologize, but this is sort of my life's work. So it's my one opportunity to talk to end users of transfusion and say, by God, get your blood bank to get some religion about ABL mismatching of transfusions, particularly platelets, and maybe looking into things such as removal of stored supernatant, which may be contributing to the immunomodulatory effects of transfusion.
This is interesting. So I'm curious to know, I don't know, Brenda Grossman, you know quite well, probably Neil, who's at WashU. So Brenda
Sure.
is.
I know Brenda. Yeah.
So I'm curious to know whether then when you do your washing of supernatant, is that post or pre leukoreduction? Because are you doing a second leukoreductive process, or
No,
is
the
it possible
leukoreduction
washing?
occurs in the blood center. Actually,
Yeah.
I've had this conversation with John DiPersio, who many of you don't know was actually the first full-time director of the transplant service here at University of Rochester before he became famous. And anyway, and we've talked about this, and it's very hard to get blood banks and hospital administrations to say, we're going to spend money on this thing that only has been studied. They studied at the University of Rochester. Nobody else wants to have anything to do with. And I understand that. It's not technically complex. It's not fabulously expensive. There's long-standing prejudice against it. We've done several randomized trials, and the patients in the washed arm have done very well. Either in terms of clinical outcomes and more like mortality, which is always important. And it hasn't made much of a dent in either the world of hematology or transfusion medicine. So I think ultimately, unless somebody replicates these studies, nobody's going to be interested in doing this. At least we could get the ABL right. In a large randomized trial where ABL mismatched platelets were given routinely, they had a 70% bleeding rate. Our bleeding rate in similar patients here is 5%. So a 14-fold difference in clinically significant bleeding. Now, it's not a direct comparison, it's different centers, but the Columbia group neurologists have shown that when you give ABL mismatched platelets, which is a routine in blood banks throughout the world, and certainly in the United States, that they have, in fact, been able to show on MRI vascular lesions that look like microthrombi in the heads, in the brains of patients who've had these head bleeds. And the bleeding is not at the site of the stroke. So very interesting abstract coming out at the American Society of Hematology this December. So I think we're just seeing the thin end of the wedge of realizing that a lot of the terrible things that happen to your patients in the ICU aren't because you don't have the skills to take care of them, but because your blood bank is doing things that are harming them. So that's good. You stop doing bad things, and the terrible things are mitigated.
That's interesting. We've got some longitudinal CAR T ICU data coming out hopefully in the next 6 months. But it'd be interesting to look at each center's treatment of their blood and platelets and see if there's a difference in the degree or incidence of CRS and ICANS.
Yeah, and bleeding, I think, as well.
And bleeding, yeah. We didn't capture bleeding complications in this study, but we did capture the rest of it. So it'd be, I think, simple enough to survey the centers.
Yeah, I
The
think
only issue though is
I'd
there's such a
suggest sorry, Ken.
the only issue though, Neil, and how would you do this is that the quantity of products that these individuals might receive is going to have a heterogeneous pool of donors, right? So how are you going to be able to refine donor specific influencing issues?
There you need to do the kind of linking of individual donors to individual recipients which are studies that have only now started to begin. And I have to say that they're focusing on metabolomics. And I think the immunologic stuff is much more important than the metabolomics, but that's just my guess.
For those in TV land, just to let you know, Dr. Loy has put in the acronym JOGMODS as your CME code for today. So I don't know what it stands for, but to get credit for CME, please use JOGMOZ. Any other questions? Stop smiling, Michelle.
Thank you. I just like that it doesn't stand for anything, but you pronounced it lovely, Jogmaz. So that I think that was a wonderful discussion. It kind of brings back this is our venture into like immunology as far as the webinars go, but you know the last several webinars have been based off of blood transfusion, patient blood management topics. So the webinars are available via this QR code or via this YouTube site that we've stored all the other webinars. Our current BloodNet research website is currently being updated, so it's not accessible there. So I know that there's lots of individuals that signed up that were unable to attend live today, so hopefully they'll be able to get access to it then. You can still get CME credit for the first 2 weeks after this is posted. And then I know there's lots of more people that wanted to get this content as well, and that's accessible there. So I wanted to thank everyone for their time during this Thanksgiving holiday, but I think we can end a little early, especially thank you to our speakers for sharing that. And then just thanks everyone.
Thank you, everybody.
Thank you.
Happy Thanksgiving.
Happy Thanksgiving.